Good morning. Today we will have a seminar presentation. It's not a very important topic, but if you go through this topic, you'll find there are some points in the topic which are often a part of theory questions, both in DNB and MS examination. So this is one of the important area of patient care. So we are including some of these more important from the point of view of patient safety. So we have three speakers today. Dr. Shakrajit Maiti is a first-year junior resident at Howrah District Hospital. Dr. Srija Rai is first-year junior resident at PLS Hospital. And Dr. Mehul Patel will be the third presenter. He's first-year junior resident at MR Bangur Hospital. So Shakrajit, you can share your screen and start presenting the first part, patient standards and quality assessment. Shakrajit, you share your screen? Shakrajit, you are muted. You have to unmute.
Hello, sir.
Yes, yes. Please share your screen.
Sir, please give me a second, sir. I don't know how to share this.
There is the option. You see the bottom of the screen. There is a share screen option. Share. Go to the bottom of the screen. You'll find there is a option called share screen.
Share documents. I find it.
Open up the presentation and then click on that.
Hello.
Yes, yes.
It is shared. My presentation.
Not yet.
Hello, sir.
We are not seeing your screen yet.
Sir, it is showing unsupported document, but okay.
It's a PowerPoint, na?
It is my PowerPoint presentation, sir.
You open up the presentation on your screen. Opened up first.
Mine also showing unsupported. Mehul, can you please play for us?
Okay.
Sir, it is tried again and again. Unsupported document type.
Okay, Shakrajit.
You can send to Mehul.
Mehul, na? He is sharing the screen. Send your PPT to me. You have not sent it.
Hello. Hello.
Hello.
Shakrajit, send the PPT to Mehul.
Okay, 1 minute.
WhatsApp. You could send it to Mehul?
Yes, sir.
Okay, Mehul will be sharing the screen and you can start. Just 1 minute. Yes. Shokit, you can start, please.
Okay. Good morning, everyone. I'm Dr. Shakwid Maiti, first year postgraduate trainee DNB surgery from Howrah District Hospital. Uh, Today my topic is patient safety and standard. The definition of patient safety. Patient safety is a framework of organized activity that creates culture, process, procedure, and behavior technology and environment in healthcare that consistently and sustainably lower the risks, reduce the occurrence of the avoidable harm, make error less likely, and reduce its impact when does it occur. It is taken from the World Health Organization. Okay. What is the meaning of safety? Safety means S for sense the error, A for act to prevent it, A for follow the guideline, E for inquire into the accident, take appropriate remedies, and your responsibility. Goal of patient safety. Identify patient correctly. A proper communication is needed. Improve the safety and high alert medication. Ensure correct site, procedure, and correct patient. Reduce the risk of the health associated infection by proper use of medicine and antibiotics. The standard of patient safety. First, patient safety with no harm concept. Health service should be patient centered and focusing on patient expressed need, exception, and satisfaction, preference, and value. Health service should be delivered without waste of time, resource, and overproduction over process. Care should be based on needs or not personal character. A standard of safety policies. Access to care and continue to care. The policies are admission the patient properly, networking of the patient, treatment procedure should be done properly, transport of the patient, and discharge after proper treatment. Patient and family rights. Proper information about the patient should be given to the patient party and the patient. Patient care should be taken properly, confidentially of the disease and security. Care of the patient, policies of the clinical practices should be taken properly, medicine preparation, storage of proper medicine and the instrument for the diagnosis, periodic clinical monitoring and evaluation, and special care, intensive care for the critically ill patient. Anesthesia and surgical care, proper pre-anesthetic checkup, surgical site preparation, and post-anesthetic care reduce the surgical hello.
Yes, you're audible.
Quality improvement by taking the sentinel event reporting and handling and processing of the. Sir, my PPT going on, I cannot handle it. Hello.
Any Mehul is doing now.
Okay.
You keep on reading. Mehul is sliding it up. Not in,
Prevention and control of the infection, proper hand washing can be taken by the proper hand washing. Disinfection, handling the infective waste, sort and specimen by biomedical waste management. Personal use of protective equipment and rational use of antibiotics can be decrease the infection. Staff quality and education, proper taking staff hiring, training and analysis their work, reduce the patient harm. Reason for the safety failure, human factor, limited knowledge, poor application of knowledge, inadequate training, fatigue, suboptimal teamwork, and poor handwriting. These are some environmental factor, complexity of healthcare process, lack of consistent administration practice, deferred maintenance, clumsy technology. These are the environmental factors that causes the harm of. National policy of the patient safety. National policy was the 2008 to 2023. Goal to ensure that the patient safety institutionalized as a fundamental principle of healthcare delivery system in improving health outcome. It is a circle of continuous learning patient. It is taken from the in-causal framework from the Ministry of Health and Ministry of Family and Welfare Organization. It is a continuous circle of learning of the patient safety. At first, patient and health workers are the engagement in the confidential. Sir, I cannot see it. Slide.
You can see the slide.
Can you make it a
You
full
cannot see the screen?
No, it's visible, but yeah.
Sir. Patient engagement and the consideration of the human engagement for the safety of the mutual respect. Then we design and learning a system. Then based on the design, we share those design and in a blame-free environment. Then from them reliable health system and recognizable responsible the community of the needs. It is a NQAS is a national qualitative assessment system. Its components some other some programs like Kayakalp, Lux, Muskan. It's in patient safety integral part of the NQAS. Thank you, sir.
Your topic was only standard. Okay. Dr. De, we can discuss for 5 minutes regarding this.
Okay. Sakrajit, I think you have covered it, but this is a general observation that I would like to make. In this topic, when you are talking about patient safety, one thing is first you should tell us about the burden of the disease, this disease. Actually, now patient safety is regarded as a disease in itself, because if you look at the WHO guidelines, then the number of complications or other incidents that occur, usually the complication ranks third after cancer in respective of the diseases. So now who is contemplating to level this as a disease itself, ICD classification. So first, I think you should have told us about the burden of this problem, the incidence. I think if you go through Bailey and Love, it is nicely written there. So that you should have mentioned, and the various ways in which patient safety is breached. And then you tell us about what is patient safety. And you have what your topic was about patient safety, but you have included some quality management aspects also. So that is my take. And one thing is, yes, it is very important that there are many other things regarding patient safety which should have been discussed. Means if you go through that chapter in Love and Belly, they have nicely written what are the pitfalls, where do we falter, what by patient safety, what does it actually mean, and means what is known by near misses. So there are different terminologies which are there. What is the shell model?
Yes. Near Mrs. Yes, sir.
A shell model you should have, because I've seen questions on shell model, short note, right?
Yes, sir.
So can
Yes,
you tell
sir.
me what is shell model? It is given in Belly and Love.
Because I just
Have you gone through? Okay, that is nothing but means the human factor you have talked about that lies in the center, and then you have various other means factors like software factors, hardware factors, and lifeline factors. So they all coalesce together to form a shell model. So you go through that. That is, it's very nicely means that chapter is an unlucky 13 in Belly and Love as far as I can remember. But then it is a very important chapter and it is very nicely written there. I think if one goes through that, then all these aspects are interrelated, and you can, and this should be known, because when you are going to be a surgeon, as far as patient safety is concerned, there are many things which we do not follow and which we do not even take into consideration, but then those should be taken into consideration. Otherwise, you have dealt with it nicely, but I think you could have improved upon this slide presentation. If you would have included all those things into it.
Yeah.
okay, sir.
If we given a background why patient safety is important, you see, the wrong side surgery, wrong patient surgery, and if you do not take adequate measures that you have mentioned, patient will have complications. Most of the complications are because you are compromising the patient safety. That is the one important reason for complication. As you come to the complications, it is infection is something we missed in the patient safety standard, that patient has gone to a complete infection. So there are some hospital policies. You see, you'll find different hospital has their own policies as to the standard of care and patient safety. There are some general standards. I agree. It will come. We'll discuss. Next speaker will discuss about the whole checklist. Whole checklist is one important part. But apart from this, there are other quality standard that every healthcare unit should implement. Okay, we pass on to the next speaker. Dr. Srija Rai is a first-year junior resident at PLS Hospital. Will present the next part of the topic. Srija, Mehul is sharing screen and you can start.
Sir, can you hear me?
Yes,
Yeah,
yes.
you can hear.
A very good morning, everyone. I'm Dr. Srijara from PLS Hospital. Today, my topic is assessment and quality improvement in healthcare. Quality improvement, we use the assessment and quality improvement to design or redesign healthcare processes to ensure more efficient, safe, timely, effective, and patient-centered care. So first of all, I would like to discuss a little about the quality measures. The quality measure is how we measure or quantify the healthcare processes, their outcomes, patient perceptions, and the systems that are associated with healthcare. So, about process measures, these are procedures and practices implemented by the staff in planning, prescribing, and delivering and evaluation of care. One example is the starting time of operating list. About outcome indicators, these are specific, observable, measurable changes that represent the achievement of an outcome of a quality improvement measure. One example is clinical audit. For clinical audit, there is 4 stages: preparation and planning, measuring the performances, implementing change, and sustaining improvement. That includes re-audit also. Then for patient perception, the patient perception is measured in base of the speed of the access to reliable healthcare, effectiveness of the treatment, continuity of the care and smooth transitions, support for their family and careers, availability of clear and comprehensive information, support for self-care, their involvement in decision and respect for their preferences, emotional support, empathy, respect, and attention paid to their physical and environmental needs. And then about the organizational structure and systems, their quality are measured in terms of availability of resources required to deliver proper care. So these are the things we take into account while we measure the quality of healthcare. For clinical outcomes and audits, the aim is to improve the quality, shorten the hospital stay for better outcome, fewer complication, reduced readmission, greater patient satisfaction, shared decision making with patient, and monitoring of clinical care. In case of surgical care, we have 2 types of cases, that is elective cases and emergency cases. For elective cases, for quality improvement, what we can do is the surgical and anesthetic checkup should be completed prior to admission. In case of emergency, there should be proper triage and resuscitation. In the quality improvement pathway, there is some steps are there. Discovering is defining the aim and vision, that is what the problem is and what are the data available. Then exploring is defining the present state and visualizing the future state. Designing is how to move and identifying the priorities. Then redefining is the testing the changes and identifying the benefits. Introducing is managing communications. Spreading is disseminating the message, and closing is sustaining the learning. There are different tools used in quality improvement. I would like to discuss 2 principles in this regard. One is the lean principle that can be applied in this operating theater settings. The lean principle says there are 7 types of wastes that we can eliminate in order to improve productivity. One is overproduction, such as we should refrain from ordering unnecessary preoperative tests. Then there is inventory, that is we should refrain from purchasing excessive drug stock. Then there is waiting. This is the surgeon or the healthcare professional waiting for the patient, that decrease the working time. Then there is waste of transportation. If there is wasting time transferring the patient from ward to OT or emergency to ward, that should be prevented. Waste of over processing, such as what is needed for a patient, overdoing it should not be done, such as giving a patient a nerve block, a spinal, a GA for a joint replacement, where general anesthesia and local anesthesia can do, should not be attempted. Then there is defect, that is the patient arrive in theater with incomplete preoperative paperwork, that should be prevented. And lastly, there is motion. In operation theater, everything should be made handy, so that minimal motion is needed. After that, for scientific business performance, there is 6 Sigma methodology. The sub-methodologies are define, measure, then analysis, improve, and control. So we should take these quality improvement measures in our healthcare system to increase the quality of healthcare and patient satisfaction. Thank you.
Okay, Srija, that was an excellent presentation, right? I think you have covered most of the aspects of quality improvement as far as a student should know in MS, right? I would
Thank you,
like
sir.
to make a few comments on it.
Yes,
First
sir.
is, you have, can you differentiate between audit and quality improvement? Are they same or are they different? Means I just want to ask
They
you.
are not same. They are not same, sir. Clinical audit is a part of quality improvement pathway. This is a tool to uh, to measure the quality of healthcare.
Okay. Now,
Quality, yes, sir.
okay, but quality improvement you have said. I just wanted to know whether you know the difference between these two. One thing that you have missed in
Yes.
these two things is whenever we do an audit or we do a quality improvement, we should rate it according to some standards, isn't it?
Yes,
Means
sir.
there should be a standard, and that standard is what? If you have gone through it, and I can appreciate that you know that there are three important business models which are given in a chart in that text, means in Love and Belly, right?
Yes, sir.
Which are
Yes, sir.
nice three. There are three nice quotes, right? So
Yes, sir.
means as far as one is very common, which we encounter nowadays in the age of artificial intelligence, is there is God above and rest is data, isn't it? So
Yes, sir.
data is so important that whatever things happen, whatever we are doing, that should be recorded and it should be made available so that we can make, because a quality improvement is different for different hospitals. It
Yes, sir.
cannot be the same model for each and every hospital, right?
Yes.
Another thing that you have missed is about, means you have defined it, but the thing is that for quality improvement, there are certain subgroups. Like quality improvement can be in a particular domain, right? Like anesthesia.
Yes.
Okay. Quality improvement can be in the OT.
Yes,
Okay.
sir.
So there are certain domains, and when one is asking about quality improvement, they should try to define actually what quality improvement they want.
Okay.
And one thing is cost is definitely a
Also,
very important factor. But if you go through the text, it is written that one business or a hospital organization should not try to means count the revenue earned from this quality improvement, right? So
yes.
that is, and if you go through there, it's nicely written that even the best of the hospitals do not have a good, we can see a nice hospital with everything in order, but that does not mean that it is providing the best quality care. Okay. And
Yes.
other thing is, from where from where have we generated all these quality improvement programs and everything?
Uh,
From where we have taken? If you go through, it's nicely written, na? We have taken it from the automobile industry and the aviation industry,
yes, sir. Yes, sir.
isn't it? So
Yes, that's
automobile
Toyota.
industry and
Yes.
aviation industry are two industries, because you have told about lean method, isn't it?
Yes, sir.
So lean method is something which is related to automobile industry.
Mobile industry.
Yeah. So what they do is whenever there is a fault in the system, they
They
stop
stop the
production.
processing.
They stop production. And the way in which they refine is they take feedback from the market, see
Yes.
what is necessary for the customers, and then
Yes.
they eliminate the unnecessary things, and then they streamline it.
Yes, sir.
So that is what is a lean method. Okay. Otherwise, means these three things, these are the things what I wanted to share with you. Otherwise, it was a nice presentation. I liked it because you have covered everything which is required for you to know.
Thank you.
Yeah. The important part is that when you talk of quality improvement, there are some markers of quality improvement. That means how many patient has wrong surgery. There is one of the, suppose one hospital has shown that they have implemented WHO checklist and there is no incidence of wrong patient, wrong side surgery.
Yes.
Then if you go to the complications, then if you analyze, audit means is not a general audit. Audit should address each of these aspects. Suppose you do an audit of infection, you do
Yes.
audit of post-op venous thromboembolism. So this quality improvement will speak of how you have gone through each of these quality markers. So this needs a continuous audit and re-audit. And then what you find in audit is you need to modify these factors and see what changes come up. So this quality improvement will come up based on your continual study. Okay, so we pass on to the next presentation by Dr. Mehul Patel. He is from MR Bangalore Hospital. Dr. Mehul, you start. These are often short notes in the exam, in both DNB and MS examination. So there'll be, and if you don't know this chapter, you can hardly write. You have to know the basic things. What are the indicators of safety? What are the indicators of quality improvement? And what are the measures you take to implement this safety and quality assessment?
Especially
Yes,
the
Mehul.
terminologies. Terminologies are very important because short notes, in DNB exams, it's given. Those terminologies are lifted from there and given as short notes.
Yeah.
What are human factors? Human factors refer to environmental, organizational, and job factors and humans and individual characteristics which influence the behavior at work in a way which can affect health and safety. Human factors can be defined as anything that affects an individual's performance. A simple way to view human factors is to think about three aspects: the job, the individual, and the organization. The Shell model gives a good idea about the human factors. The S stands for software, H for hardware, E for environment, and L for live wire. The live wire is the human. The first interaction is the hardware. The hardware-human interface considers the use of equipment and how ergonomic and practical it is to use. The live wire software interaction, the software includes guidelines, procedures, and documents. That must be easy to implement and use. The live wire environment interaction. Environment is a key. The noise, movement, light, amongst other factors, all have a direct impact on the transfers. And the live wire component, where the human-human interactions are crucial in human factors. Example: leadership, teamwork, and personality interactions. The edges of the Shell models are all uneven because these all components are interdependent and not static. The job includes the nature of the task, workload, and the working environment. This includes matching the job to the physical and the mental strengths and the limitations of the people. The individual, it includes competency, skills, which are changeable, personality and attitude, which is fixed, risk perception, sleep deprivation. Individual characteristics influence behavior in complex ways. The organization includes the culture of the workplace, resource communication, leadership, and so on. Now, types of incidents. Incidents, an event or circumstance which could have or did harm to a patient. There are three types of events: near-miss events, an incident which did not reach the patient; no harm incident, an incident which reaches the patient but did not cause harm; and an adverse event, an incident that has harmed the patient. The Heinrich safety pyramid says that for every 300 near misses, there are 30 minor accidents, and for every 30 minor accidents, there are 1 serious accident. The benefits of applying human factors in healthcare. Awareness of human factors can help us to prevent medical errors, understand why healthcare staff makes errors, identify system factors which threaten patient safety, and to prevent occupational accidents and ill health. Medical errors, example, dispensing expired medications, unplanned hysterectomy, wrong sponge counting, wrong patient ID, went to the wrong procedure, wrong medication delivered, or wrong dose administered, etc. There are two types of errors: active failures and latent failures. Active failures are those which are done by the ground staff, that is the human performing the task. And the latent failures are the decisions taken by the higher authorities. These two failures, though the Swiss cheese model by James Reason states that multiple barriers or defenses should be set up, but these defenses are full of holes. The holes represent the active and the latent failures. Now, multiple active and latent failures when line may come in line and cause an error. Causes of medical errors, healthcare complexity, complicated technologies, drug interactions, intensive care, prolonged hospital stay, and multidisciplinary approach. System and process design, inadequate communication, unclear lines of authority. Environmental factors, overcrowded services, unsafe care provision areas, and areas poorly designed for safe monitoring. Infrastructure failure, lack of documentation process, lack of continuous improvement process. Human factors in ergonomics, the patient's emotions can be angry, hungry, late, lazy, tired, fatigue, lack of sleep, lack of skilled workers, and lack of training. Actions to reduce medical errors as related to human factors. At the individual level, we can help to manage the stress. Focus first on the tasks that are high risk and where it is particularly important. In emergency situations, use algorithms and protocols. Quickly allocate a clear leader and consider if there is a way of running a simulation with your team. Complex calculations. Find out if there is a pre-calculated list available. Before we start a task, think about ways in managing and avoiding distractions. Look for dose strength of ampules in the drug cupboard and double check with your colleague. Storage, look at the products you use and have stored. Example, look like packaging. Physical demands, physical tiredness, get enough sleep before the duty. Demands exceeding capability. Most people at some time overestimate the abilities and underestimate the limitations. Teamwork, briefing and debriefing can help teams to develop a shared mental model of a planned procedure or a patient's clinical status. The S-bar, situation, background, assessment, and recommendation. Also, poor lighting, look at the lighting in the areas where you need to perform the complex tasks. And at the organizational management and human factors, developing a positive safety culture. Just culture, reporting culture by reporting the near misses event, learning culture, morbidity and mortality review process, the audit which we talk about, and human factors, training in the healthcare, and developing clinical practice guidelines, protocols, algorithms, checklists, etc. Thank you.
I think, yeah, Dr. De.
Yeah. Mehul, it was nicely you have projected the human factors. Yes, human factor is as I was saying before, human factor is the core of the shell model, right? So if you look at the shell model, you have two live wells. So human factor is the core. So we can,
actually, WHO checklist should have come here. WHO checklist should have come here.
I was just about
You
to say
that. Because human factor, most important part to avoid human factor is to implement the WHO checklist. And you should have talked about the background of developing this checklist and how do you implement. Yes, Dr. De.
And means apart, if you look at the human factors, see, humans alone as a surgeon, you have as a surgeon, you have the responsibility. But one thing that is written there is very important is we should have a team effort, right? CRM that we say, isn't it? So we should have a team effort. So core team formation should be there, and everyone in the team should be allowed to speak. Means what happens is in our setup, what we see is when suppose I am taking rounds or someone is taking rounds, then what it happens is my decision is the final decision. So that is a very wrong way of seeing things. Even an intern who is there, if he suggests something, we should take it into account. And the other thing is, you have mentioned about human factors, but system factors are very important to govern the human factors, right? This is very much important because our system currently is a type of a punitive system. Means there is always a sword hanging above our head. So that makes us less comfortable or less flexible. If you see that this word flexibility is written, So it makes us less flexible to work. So it is also written that the core means the system factors should involve, or the human and the system factors should work in conjunction, and that the system factors should have a leader or a mentor who should be means advisory in nature, means he should advise, not to put a blame. So if you try to put a blame on someone repetitively, then what happens? The performance decreases. So that is also one thing. And like what you have said, there is a good proverb, to err is human. So every human factor has got a failure, but then we should be very cautious. Yes, those two models that you have described, the pyramid model and the Swiss cheese model, those are important, and we should take every steps so that we do not create mistakes. But still mistakes will occur. But then as you see the pyramid, means we should focus on the near misses, and also we should take lessons from the events that have been performed but that have caused less damage to the patient, rather than events which usually cause direct injury to the patient. So that is what I have. Human factors, there are so many other things also in the human factors. And it is one of the key means milestone or the keystone in this shell model. So that is what I have to say. Otherwise, you have covered it.
Yeah. And regarding the system factors, you see, these patient safety starts from when you plan the infrastructure development. Suppose if you are planning wrongly, then your patient safety will compromised. Suppose you are planning an operation theater complex. Then from the beginning, you have to think that there should be an area where people should change their shoes, there should be a change room, there should be a transition zone, then come to the absolute sterile zone. So this system factor is very important. These start from the time of planning of your healthcare system development. So this patient safety is not that you just talk of patient being wheeled into your setup. This should start from the beginning. You see, fire safety is one of the important safety measures in general patient safety. And for fire safety, there are a lot of factors. What you should take, you should think of a volatile liquids in the theater. You should think of the other flammable articles which are in the theater. So there are a lot of things. Fire safety is another important patient safety factor. We have not touched that also. Okay. So there are a lot of things in, and the system factor should take into account. You see, doctor is one part of the healthcare system. Apart from this infrastructure, this management part is again a very huge part of quality improvement and patient safety factors.
Another
Okay,
thing,
Dr. Dev,
I just want to add is, I saw one question on patient's journey, right? So I saw one short note. So I think it is written there in that chapter also. Means patient journey for an elective operation, a patient journey for an emergency operation. So that is also, once I saw one short note. I was checking one DNB answer script where I saw that. So I just remembered. So that is, I think, given in this chapter. So you also need to go through that also. Otherwise, thank you, Makunda, for this chapter, at least for me, because I read it 3-4 years ago. But when you gave me this, I again went through, and it was very nice to go through that chapter once again. It was a revision.
I intentionally kept your name for this topic.
Yeah, it was. Thank you, sir. Means otherwise I wouldn't have gone through this chapter again.
I would have liked that they become more elaborate. They have not touched other aspect. You see, the fire safety, the safety of the healthcare personnel itself. Healthcare personnel safety is also important. That means infected healthcare worker. Then you see, a healthcare can be HIV positive, and how he should behave in the this healthcare setup. What precautionary measures he should take. Okay, and then the other theater sterility. You see, there are a lot of things in the theater sterility also. Okay, there I think I was expecting a little more elaborate presentation from all the presenters.
Ah,
They have touched, but the whole chapter is not covered.
exactly.
But somehow, at least it's an
Ah,
eye
it
opener
is,
that we are thinking of this chapter also. This chapter
it
is
is
not something
important.
not to be read.
It is important because apart from reading, there are so many aspects in this chapter which one should follow as a surgeon also.
Yes,
So I
yes,
think
yes.
it is a very important chapter also in that sense.
And I find 2-3 years back there was a question on MS was there. Does WHO checklist?
Ah,
And if you are given a short note of WHO checklist, you have to write the background, why this checklist came, and who you see. Atul Gawande is one of the important person who are behind this creation of the WHO checklist, because he has gone through a lot of such situations, the near misses, that's, and the background is again automobile. And you see the aviation industry, the pilot as he in the cockpit, it does not start the flight straight away. There is a defined checklist. They have to tick all the points. Like the checklist in our theater. We are not doing regularly, but that is one culture. You should develop that. We are implement the checklist. And I would request everyone to read the WE checklist, the background, how it was divided, which year it is implemented, and who are the persons responsible for implementing this checklist, and what are the advantages by implementing this checklist. Okay, that is one important part we should see.
also, Makunda, I would like to thank you because once I was going through this chapter, I thought have started writing what are the lessons taken from aviation and automobile industry for a surgeon. So I'm writing
Yeah.
an article on this. So I have
Okay.
nearly completed that. Had you not given me this topic, actually, I wouldn't have thought of it. While going through, I just thought that there is no such article which is written. What are the cues we have taken as a surgeon from automobile and aviation industry? So I have just
Yes,
I've written that article. I will send it to for publication. Once it gets published, I will share it with the.
okay. Thank you. Thank you.
Okay. Thank you, sir. Thank you.
Thank you. Thank you very much.
Thank you, sir.
Thank you all the speakers. Thank you.